as Leslie said, I really have had the privilege in my career to visit spend time in just about every rural hospital in our state. And brand new hospitals like the new hospital that was the first and only hospital in San Juan County, the hospital in Friday Harbor, working with Chelan, Klickitat, Prosser, all of the rural hospitals that are being really forced today by the federal government and all the changes in rules to really look at how they deliver care and make sure that they can produce quality outcomes, the same outcome that you would get at Sacred Heart or that you would get at OHSU or Swedish, to be cost efficient and to deliver high patient satisfaction. That's what the government is telling us. That is where healthcare is headed today, and it doesn't matter if you're in a big downtown hospital or in a community. And it's harder. A lot of the rural communities, rural hospitals, at least in Washington, were built with Hill Burton funds that came in the late 1940s, early 1950s, and the hospitals are dated. They're old, and it's hard to provide some of the care that the community needs, especially as the community ages, because people need different services as they age. And so I'm just going to go through the data. We've spent maybe about 2 years talking about or collecting data. And I'm just going to present the data that we did. I want to do it in about 10 to 15 minutes, and then I want to be quiet. I want to hear from the community. We have some questions, and we really want to have a conversation about what does the community want, and how do we move forward at this point in time. So there's your district. You know the boundaries, just about the boundaries of your public hospital district. Centerville, Goldendale, Klickitat, Roosevelt, all portions of those zip codes are included in the district. And we spent time in both 2018 and 2019 collecting data. And I'm going to tell you what that data showed us at that point in time. And again, this is just actually the facts. So I don't know if everybody can see that, but the district's population grew at a little less than 3% over the 2010-2017 timeframe. It's projected to grow another almost 4% by 2022, and then by 2030, which seems like forever, but it's 11 years from now, and when you're looking at building and investing in facilities, you want to go out that far, at least that far. We're expected that the district is going to grow by about another 6%. So in 2017, the population of the district was about 8,300 people. By 22, we're expecting about 8,500 people, 8,600 people. So the absolute ends are not that small, or not that large. And in 2030, we're expecting about 9,000 people. But what I want you to understand, these are very key statistics here. 100%, all of the growth that occurred in this count in your district between 2010 and 2017 occurred in the elderly population. You actually lost younger residents, and all of the growth occurred in the 65 plus population. We expect that I know that there's some discussion about all the new industry that's coming into the community, but the data right now suggests that we're going to continue to see significant aging. And why is that important? So today, about 27%, so more than 1 out of every 4 residents in your district is over the age of 65. We're expecting that that's going to be 30% in the next couple of years. And people over the age of 65, again, the National Ambulatory Care Survey, the state of Washington's inpatient databases, all of the data tells us that people over the age of 65 use healthcare services about 3 to 4 times higher rates than the under 65. And so when we're looking at how much services are going to be needed, we need to make sure that we have services available for the aging and growing population. Questions about that, or should I just keep moving? Yes.
I'm curious as to how you gleaned that data, because we moved here in 2012. We're both under 65.
And 3 children under 65.
So that data comes from 2 sources, well, 3 sources. It comes from the U.S. Census Bureau. It comes from the Office of Financial Management, which is the state of Washington's It's the data collected by the state, and it's used to determine how funds are allocated. And it also comes from a national database that we buy data from called Klickitat. And so it doesn't mean we don't have younger people, but more younger people out-migrated than came to the community.
Right, okay, but so what you're saying then is the growth is 100% in the 65 and up, and if you take younger than 65 and sort of offset the decrease, is that what you're saying?
There's actually a decrease in the number of people under the age of 65.
I think our point is that we get really nervous when we hear things like 100%, because we've already seen holes right here, right now. It's not 100%, because there's 5 of us, and I can name about 4
But
families.
10 left. That's what the data's telling us. That's what the data
You're
left.
taking offset of what left, plus ones that came in, you're still at
That's correct.
a
That's
negative
correct.
growth
That's
factor
correct.
for
All right.
under.
Right, and we're tracking that, and you know, over the last couple of years, we've talked to the hospital and the district about tracking that, because if there is a lot of new employment opportunities, that's going to begin to change. But right now, the best data tells us that we know historically what has happened is accurate, and it's telling us what they're trending into the future.
And I would agree that that's certainly the trend.
Okay, thank you. And then now let's talk about healthcare utilization a little bit. And I'm sorry I've got all this data on here. So we looked when we were doing the data collection back in 2018. We took a look. The state of Washington has a database. You folks may not know about this database. It's an incredible database. Anybody that's a resident in a hospital overnight gets added into this database. We don't know your name, but it tells us the zip code, which hospital you went to, how long you stayed, what the charges were associated with that stay, what the procedures and the conditions that you had during that stay. The state of Oregon has the same exact database. So we combined those databases for your community, because people go both to Oregon and to Washington, and we said how many people were hospitalized.
Is that database segregated in any way, shape, or form between Eastern and Western Washington?
It's one large database, and you go in and you look at this by zip code, or by hospital, and you can pull out any data that you want. It's a pretty amazing database. So it tells us that annually, over the period of about 2013 to 2015, anywhere between 850 and 900 district residents were hospitalized in a hospital, either in Oregon or Washington, during that each year during that time frame. That averages about 10 people a day. So about 10 people in your community on any given day were in the hospital for some reason. About 120 to 125 of those hospitalizations were for things that would never be done in this community: cardiac surgery, interventional cardiology, neurosurgery, trauma, the tertiary kinds of services. Another 70 or 80 per year were for babies being born. And I know over the years as I've worked here, people keep saying, what about OB, what about OB? About 15 of those, when you look at the data, again, would never be able to be delivered here, simply because either the mom was high risk or the baby was high risk. And so you're talking about probably less than one baby a week being born locally in the community. And those numbers, we have basically no hospitals in our state right now that deliver with that kind of delivery volume. It's too hard to keep skills up at that point in time. I see head shaking in the back. So, about 25%, 30% of all of the hospitalizations occurred for district residents occurred at this hospital. The rest went to other hospitals. But there's a lot of other things going on in this hospital. So about 200 observation stays in the community. So people that went to the hospital, stayed at the hospital, but were never deemed to be an inpatient. There's about 200 of them a year. And KVH every year had about 80 to 90% of those. And KVH also operates a swing bed program. So people that are no longer medically acute, but need some additional services before going home, and they're capturing about 95% of all of that volume. So pretty high volume. And then ED visits, I take this as a good thing. So even though the community is growing slightly and aging, we're actually seeing a decrease in the number of emergency room visits annually out of district residents. And I attribute that to that first bullet. So KVH has recruited about 20 providers to the community since 2017. And when you have more providers and people can get access, they're less likely to decide at 8 o'clock at night that they need to go to the emergency room. And so we see that in communities with strong primary care bases, and in communities where there's primary care deficits, we see we see emergency room visits that don't really need to happen.
So Jody, I just want to clarify, that is throughout the district. So it could be in the clinic, it could be a hospitalist, it could be ED physician, it could be a physical therapist. Those are providers throughout the district.
Thank you. And then let's talk about outpatient services, because that is where the growth is occurring in healthcare nationally, in Washington State, and in rural Washington as well. So district residents' use of outpatient services, including outpatient surgery, grew pretty dramatically between 2014 and 2017. And I know I'm switching years on you. We were looking at 13 to 17. Now the database for outpatients, so this incredible database I told you that the state has for inpatients, they don't have it for outpatients. So we buy this data from IBM Truven. They collect claims data, so they have a very robust database. And we're able to go in and look again at the zip code level and see what's going on. And what we're seeing here is that, for example, let's look at endoscopies. So over the period of 2014 and 2017, the number of district residents, regardless of where they had that endoscopy, it went up from 460 to 625. So pretty significant. The community's not growing at that rate, but the number of endoscopies went way up during that time frame. And KVH did about 53% of them in 2014 and about 85% of them in 2017. So the community's really looking locally for those kinds of services. There were about 1,700 outpatient surgeries performed on district residents in 2014, and again about 2,000 in 2017. So good growth in outpatient surgeries. The percentage at KVH went up 300% during that time frame. There's still room to grow. Their facilities are somewhat limiting, but they had nice strong growth between 2014 and 2017. Things like mammography, the volumes were flat. You could expect that with an aging population. The percentage at KVH increased from 40% to 70%. So again, the community is really relying on those diagnostic services being done locally. And then the data, newer data, KVH family medicine prescriptions in 2018 totaled nearly 50,000. So out of KVH's family medicine program, about 50,000 prescriptions were written, of which 60% were filled out of the community. And I understand that's by patient preference. That's correct? Yeah.
I've got a question on like your mammography. These aren't taking into account the fact that they brought in new technology. And so, I mean, that's on the mammography. I think that was a big part of it. They started being able to do stuff they weren't able to do before.
And that means the facility is much busier. I'm looking at how many people are coming in to the facility.
Yeah, but
that's a good thing, I would think.
Well, yeah, but
a marketing point.
Well, yeah, but it's a situation where it's, I think the driving factor is the fact that it's available, whereas before it was over in the house.
And that's really kind of the point on a lot of the services that we want to provide. We see that we have a lower market share, but if we had the technology, if we had the equipment, or if we had the provider that had that skill set, people will come locally for services if we could provide them, and that validates that.
To a certain extent.
To a certain extent.
Yeah, but
Okay.
there's some.
Let's keep going. We're going to have a great opportunity to talk about this. Yes.
Regarding prescriptions, we go to Yakima to get our prescriptions. The local pharmacy doesn't use our insurance company, so that's the reason we go to Yakima. Would you be using, or would you be available to use all these insurance companies that support us?
So that is our goal. We are hoping to open our outpatient pharmacy in the next month and a half. Yvonne is the new owner of KC Pharmacy. She provided us with a list of the insurances that she is contracted with. So we're matching that up against the people that we know we provide services here to see where those gaps are. So if there's a contract that KC Pharmacy doesn't have, we're trying to see if we can get that contract. There are some insurances that aren't going to contract with either one of us. And it's not KC's fault. It wasn't Connie and Carrie's fault. It's just the way that they do business. But if there's a way that we can fill those gaps, that's really our goal, is try to complement the service that KC is offering and be able to provide those, because the data does show that people have to go out of the community for whatever reason. I know that when Yvonne got here, she asked for some feedback and wanted to know maybe there were some insurance companies that she could do sign contracts with. And so we tried to provide that feedback to the clinic for her to say, these seem to be ones that people were having to, and we can track this now because of all the electronic prescriptions. So we know exactly how many went to Bimart and the Dow's or Fred Meyer or Walgreens. And so we tried to give her as much feedback as we could, what we heard from patients, but it's patient's choice. When the physician or the MA says, where would you like this prescription sent, the patient gets to choose. And sometimes they know that they're not able to get that filled locally and they have to go out of town. So it's based upon data, and we saw that those numbers kind of increasing over time as we've been able to track those with the electronic system we have.
So I'm going to try to move through this because we really want to have a discussion, but thank you for the questions now. So we also, when we were collecting data, again, we looked at the demographics of the community, the age of the community, the growth in the community, and we identified a number of other services that really we expect the volumes to grow considerably. And I'll just go through them quickly. So wound care, between 2014 and 2017, district residents seeking wound care, regardless of where in Oregon or Washington they were going for that care, increased about 30%. We expect that to continue to trend upward at a pretty rapid pace. Dental services. So the federal government has designated the district, actually the entire county, as what they call a population dental professional shortage area, meaning there are simply not enough dental providers to provide care to residents. Adult dental disease, at least when we did this study, was the 5th most common reason people came to the hospital's emergency room. Heart attacks, other things, dental came in 5th. The Columbia Gorge, so all the hospitals in the Gorge did what's called a Community Health Needs Assessment together back in 2016. And in that Community Health Needs Assessment, they identified that access to dental care was the greatest unmet healthcare need in the entirety of the Gorge. So that kind of puts some statistics in perspective. And what we see is that if you're on Medicaid, everybody has adults have access problems, but if you're on Medicaid, the problem is even more severe. So 1 in 4 don't have access. So that's why we made some recommendations around dental services. You were, in terms of closure of the local nursing home, your community was early in that process. We are seeing a lot of rural communities lose their nursing homes right now. You have really no skilled nursing beds at all in the district, and that really impacts people needing post-acute services, long-term care services, and we're going to continue to see that trend. And right now it's had a pretty significant impact on the hospital swing beds, and we expect, again, as the community continues to age, we'll see more of that. And then behavioral health, so I'm talking about mental health services and substance use services. Again, the federal government, just like it did with dental, has named the entire county as a, whoops, that says dental, that should say is a mental health, behavioral health shortage area. I apologize for that. And the state Medicaid program, so Washington State Medicaid program has mandated whole person care, meaning we no longer cut people off at the neck. We're going to treat their head and we're going to treat their bodies together, and they are requiring integration of behavioral health into primary care. And again, KVH was an early adopter of some of those changes. And as I understand, you already have more waiting lists than for providers, access to providers than you can care for. So those are the kind of trends we're seeing in healthcare, that again, when a building was designed 70 years ago, none of these things were assumed to be part of a hospital facility. And a lot of people every day come into KVH looking for those kinds of services. So I'm not going to bore you with this, but in my world, and it's exciting for us that do these kinds of things, we try to estimate we do estimate the volumes of people that we think are going to come for all of the additional services, all of the services 5 years in the future, 10 years in the future. And then we convert those into space needs. How much space is needed to provide care for that population? And I've given you this little book because it's the book that the state of Washington uses to say, do you have enough space, and are your spaces the right size to do that? They're called the FGI guidelines. And they're kind of the Bible of people like me and architects and others. And when the state comes out to survey, a lot of times they're bringing that book along to make sure that the spaces are adequately sized. So what we identified through this process was a need for about 7 to 8 inpatient rooms in the future. So again, not that much growth on the inpatient side, but about 7 to 8 rooms with the capability to be able to adapt to surge. You know, when there's a flu epidemic, when there's a natural disaster, just the ability to surge capacity. So that was our recommendation there. ORs and procedure rooms. So operating rooms and procedure rooms. We're thinking, our data says 3 rooms are needed. We've got all those endoscopies, we've got the outpatient surgeries growing, we've got inpatient surgeries happening, and the community's aging. And 1 additional room was our recommendation, would be very beneficial because it really would promote efficiency. It would allow staff not to have a lot of overtime because of delayed procedures and longer days. It would hopefully reduce costs, and importantly, it would provide space for visiting specialists. So we heard, and I'm going to talk about this in a few minutes, we heard from the community when we did surveys and focus groups that the community wants to stop traveling for services that could be available locally, and that 4th room would give that flexibility. An outpatient nursing treatment area, so these are short stay patients that are coming in for things like hydration, wound care, dressing changes. Again, the data is telling us we're going to see large impact in that area, and our recommendation is 4 treatment rooms, treatment bays to manage those patients. And then what we found is that the hospital today is undersized in a couple of areas, most notably in the nursing unit. So that nursing unit is 70 years old. And it's not code compliant based on square footage. So the rooms are much smaller than you would find in a contemporary hospital, in a room to not only accommodate all the equipment that now comes into the room, but the family as well. And that little blue book has set the requirements for how much space should be in a patient room. And then again, your operating rooms are simply too small. At the time that they were built, there wasn't the equipment needs and the staff needs that we see in operating rooms right now. So the square footage of those operating rooms is limiting the kinds of surgeries that can be done today. And in the end, the hospital selected an option to simply expand the current facility by about 24% increase in square footage. A replacement hospital would have been about $45 million, and it was deemed not to be the best option for the community today. As I said, we did a series of focus groups and community surveys in 2017 and 2018. This says more than 400. I actually looked back today. We had 460 people complete surveys, either online or via phone. That is an incredible rate of completion.
How many calls were made?
I don't know that. I do have that data. If it's important for you, I can get your answer.
I think it would give an indication of maybe the percent, because there were a lot of people that had.
Probably every house, these are, so again, we are limited to landlines, so if people don't have landlines, they're given the option to complete an online survey. 460 complete surveys is a statistically valid sample size with a 95% confidence interval. And what that means is if we did that survey again, within plus or minus 5%, we would get the same results. So it's a very strong sample size. Got to end with a high confidence interval. I'm sorry?
Right, but 400 out of 500 is a bigger percentage than 400 out of 800.
Oh, we probably, the entire community was surveyed.
I wasn't
I
surveyed.
wasn't.
Okay.
Yeah.
We can, if you want, you can give me your phone numbers and I can look to see.
I would really like to know what the total sample size was.
The sample size was all of the landlines available in the district. And I can get that number and make sure I get it to you pretty quickly. My guess it was probably 3,000 in that range.
So 400 out of 3,000 isn't a real high percentage.
It's not the percentage, it's the confidence interval.
Yeah, well,
And the confidence interval is very strong.
And what does that mean?
What that means is, so it's a statistical test. And
No,
what
I
it-
understand.
What it means is that we have a reliable sample with test-retest reliability, which means that if we did the survey again, within plus or minus 5 percentage points, we would get the same results.
There's a real science to
It's a science.
this. There's a real science to
Well,
it.
there's real science on it.
There was some commentary about, basically, there's 8,000 people. 400 is not a bad number out of 8,000. That's a pretty good number.
It is a good number.
I don't know that I'd complain about
These are
that.
households, and it's 460. So, yeah, it's a very good, it's a strong sample size that gives us a lot of confidence when we're looking at the analysis. What we heard from the community in those surveys is that be careful, they think the population is going to grow faster, and we've already talked about that. So I've got that on my watch list. More than 70% of the respondents to the survey, and we also did, in addition to this, we did 6 focus groups and talked to about 75 people in those focus groups as well. More than 70% told us that their primary care provider was located in Goldendale, and that they had, and those that had experienced an ED visit in the last year, 85% told us that that emergency room visit occurred here at KVH. The top desires of local residents, what they told us they want, is more options for same-day care and access, and after-hours and walk-in care. That was a top priority. More specialty care locally, appropriate specialty care that they shouldn't have, that they don't feel like they should travel outside of the community for, was a priority. Reduced out-of-area travel was a priority, and better access to pharmacy services. So those were the top 4 needs that people told us that they saw in the community. They also told us that they were eager to have more information about KVH, how it's performing, what it's going to do to recruit and retain staff, what services it provides, who its providers are. There was a fair amount of interest in understanding more about the hospital. Now I'm going to switch quickly, and I'm taking up more time than I wanted to, but I'm going to tell you a little bit. As many of you know, the Chamber actually put a survey. Is it just online? Is that how the Chamber did it?
Yeah, it was just online.
Okay, so the Chamber put a survey online maybe about 10 days ago, is that right? And as of Friday, 116 people had responded to that survey. 57% were under the age of 65, and 43% were 65 plus. I just want to show you quickly the results from that survey. So what we asked was, what the Chamber asked was, were you aware of the August 6th vote? Did you vote? And how did you vote? And what we found is that what they found was that the vast majority, and I'm saying we because we just got the raw data and we looked at it, but it was their survey. About 95% of the community was aware that there was an election being held in August. And about 62% of those that voted in favor of the bond, and those under those that are 65 and over. And so you can see the gray is did you vote yes, Did you vote no, or did you not vote? Or did you not want to tell us how you voted? So that's what the data is in this table.
Those don't match the auditor's office numbers for the percentage that voted yes.
Correct.
Oh, no.
But these are the survey respondents' votes.
Yeah,
This is
this
the
is
people that
not,
took the survey.
this is probably not a statistically valid survey. This was more of go out, canvas, go ask. I put it together and sent it out. So.
If the vote would have passed if this had happened.
Right.
Right.
So these are people that, as of Friday, had elected to take the survey. And what we're trying to understand is why they voted how they voted. And so 40 people told us that they voted no, and 36 of those gave us reasons for why they voted no. And you can see, here are the top reasons that they voted no. Number one is dissatisfaction with the current hospital, things like customer service, wanting to see more staff training, more staff development. Those were the top reasons that we saw that people said we're just not happy with the hospital today. Or that the next most common reason was that they didn't think that the project as developed or packaged by the district focused on the right priorities. These two get really close together. They also thought that the project as packaged was not the best option. I was sitting here listening to people talking, and I heard fluff, that there was some concern that maybe there was fluff in the project. Too expensive or too extravagant, or that the hospital didn't demonstrate need. So 5% thought that the district didn't demonstrate need. And so what we want to do, I want to just let you know what happens in other rural communities, and then I want to have a discussion. So since 2011, 7 rural public hospital districts in our state went to the voters asking for bonds, either for a replacement hospital or an expansion to their facility. 60% of those projects needed a second, and in one instance, a third vote. The third vote is Chelan. The community in Chelan is in the process of getting a brand new hospital at this point in time. But I wanted to just go through these in case anybody has questions. So the hospital in Ritzville, you can see that they went a couple of times. The hospital in Chelan, we've just talked about that. Okanagan County Public Hospital District number 3. I should know that. I think that is that's not Brewster. I think it is. Does anybody else know? It's somewhere up in the Okanagan. They went twice, and then the hospital in Pend Oreille County, so that is Republic, went twice. So it's not atypical for a community to feel like they don't have enough information to vote definitively on a project. And I just want you to have that perspective as we go through the conversation tonight. So we'd like to have a discussion, or I'd like to have a discussion, understand where the confusion was, what the concerns are, and what you'd like to see happen next.
I'm saying if my mammogram, which would have been easy to bill, Medicare, and then my secondary insurance, if they're struggling with that, is this hospital fiscally sound with $19 million doing it the right way? I think it's finally taken care of, because I haven't gotten another, but it was ridiculous. And then the second reason, and this is, if I were to, this is what I want from Klickitat Valley Hospital. I want clean rooms, I want competent staff, and if I need to get out of here, I want somebody to say, I can't handle this, we need to get you out of here. I don't want anybody guessing on my health care. If they're starting to guess, I want somebody to be brave enough to say, I don't know. And I do think that we do need some long-term care beds. I don't think we need healing rooms with the view of Mount Adams. I think that's the fluff. I think we need good, solid, clean rooms, period.
Thank you for sharing.
And then I need somebody, my mammogram is not scheduled here. I do use Dr. Miller as my primary provider, and I did notice that they were able to bill Medicare and my secondary insurance the right way. But everything else we've scheduled out of Klickitat Valley Hospital for the time being.
Okay. Thank you for sharing. And I will tell you again, in all the rural communities, in all of the hospitals, every hospital in every community. And I can't explain why, I don't have an answer, but
and I'm not gonna argue the point, there's a lot of,
it's a common issue.
why?
Can I explain? I'm Brenda, I'm the new business.
Why?
I'm the
Okay,
new
Brenda?
business office director. And to let you know, not a why, but to give you why the new one, your new claim with Dr. Viller went through correctly and paid in much less time. In April, actually in March, we started a process to upgrade our current billing system, our patient financial system. So we've now got where instead of where in the past, we used to push bills out and then our billers had to work at trying to figure out why it didn't get paid. Now, since the first week of April this year, the claim stops before we bill it. If the diagnosis doesn't support the service, whatever the case may be, we've got it coded, we have it, we're missing charges, things like that, well, now the claim will stop ahead of time so that we have to fix that problem before it goes out to your insurance.
So, and you're also working, now I don't want to sound snippet right now, but you're also working that people will start returning your phone calls?
Yes, ma'am, we are.
Because I never got a return phone call. I called at 8 o'clock in the morning, I called at 5 o'clock at night, I tried to call right after lunchtime. And I finally got a hold of somebody who said, well, you told us that we didn't have to bill Medicare.
That's probably we're talking to me. And we finally got it squared away, but the reality of it is I'm currently working on that process with the departments to be able to identify the AVN process is not necessarily appropriate right now.
Okay.
So we're working right now with the departments and my staff and medical records to resolve the issue.
Thank you.
So that will be something taken care of. I have 37 years in the business office. Started out as a collector and worked my way up. But we are doing everything in our power, especially, it started before the bond, but definitely since the bond. My staff has been informed to return phone calls within 24 hours. If that's not done, then I need to hear from people that it's not happening.
Thank you.
Yes, ma'am, absolutely.
Thank you.
So Barbara, I just want to say, we recognize that we did receive the community feedback. One of the reasons we hired Brenda is we realized we need to do a better job of doing this. Like, we are getting these complaints, we need to, systemically something's wrong.
So, and then you can see how, first of all, you see this happening, you think they're not collecting money, and now they're asking for $19 million. And I'm thinking they can't even take care of the money that they've got coming in if they can't get the bills out, if they can't. So there's a little lack of confidence right now. I did notice that the one bill came through very fast. That was nice.
So hopefully you'll see more of that.
Hopefully that will
Well,
continue.
you probably won't see more of it from us unless I go through Dr. Miller, because we are scheduling things out of the area for the time
Well,
being.
hopefully we can make you change your mind sometime in the near future. Because that is definitely our purpose, is for you not to have to go out.
Thank you.
Yes, ma'am.
Okay. Don't get me wrong, I do love this hospital and I love the staff up here. But I know my mom also had questions about billing one time. And instead of getting somebody here at Klickitat Valley, she got somebody clear up in Spokane, Idaho.
Spokane. We only have enough staff to handle what we've got right now. And so, yes, we have outsourced some of our business, but it's insurance accounts that are 61 days and older, trying to clean up our AR for us so that we can focus to keep from moving those accounts further out for somebody else to have to take care of. So we want them to take care of some of our old stuff, and we're focusing really hard with them right now on that aging buckets.
What is the current accounts receivable balance right now?
Yes, Jamie.
So I actually think a better reflection of that are the gross days and receivables. So Jamie pulled some information so we could look at where were we 10 years ago, where are we now? So do you want to?
Yeah, so some of the data I wanted to take a look at is, how are we performing 10 years ago versus now, and how much has the district grown? Am I not loud enough?
Maybe stand up.
Do I need to stand up?
Do you want to come up here, Jamie?
Go ahead and stand up.
I don't want to be in the sunlight, but yeah, so we pulled a bunch of data, which
Sunlight's
was
good.
sunlight. I probably need the vitamin
Makes
D.
you
We're in
grow.
Washington State. So, so taking a look at the data from 2009 to 2019, and I pulled August just to be a good comparison. And when we're looking at net revenue in the district from 9 to 19, which for someone like me, I've been at the hospital that entire time. 10 years has gone by really fast, and you forget kind of the growth that's happened throughout the district. But in that time, our revenues increased 37%. So then we've also taken a look at what does that mean for claims? What is that difference and significance that's happened in the 10 years that would affect the business office? And so with the claim growth, that's also been at about 20% claim growth. And so we're in a rural community, it's sometimes hard to recruit staffing in particular areas. So as Brenda was mentioning about having this company in Spokane. So one of the things that was really important to us, if we had to look outside of the district walls for some services and help for those services, was to have someone at least as local as we could be. We didn't want somebody overseas trying to call, because that's usually very alarming for patients. And so there's a great company out of Spokane that works with a lot of rural communities. That's really what they focus on, is business offices. In some cases, they take over business offices. That was not our goal. Our goal was not to outsource the entire business office, but to be able to have some support to help with some of these claims that we've had so much growth in. So right now, as Brenda mentioned, they are helping us with these claims that are older claims to make sure that they're getting worked, because there's some statistics out there, and I didn't bring those today, but there are companies out there, for insurance companies, that there's requirements for them to deny bills the first time that they come in the hopes that these rural small companies do not have the time to go back and do the appeal process to make sure that your insurance claim is processed correctly. So then it's up to our business office to go back and do those appeals for those patients. And that's sometimes where you see it can be a year before you receive your hospital bill, because the business office has had to go back and fight with that insurance company 2 or 3 times. If you have a secondary, once we can't bill your secondary till your primary pays. So once we get that worked out with the primary, they then turn around and bill that secondary. And so this company is really helping us through that process to make sure we're getting those processed just as quickly as we can. We have 8 employees in the business office currently. Of those, 5 of them are billers. So they bill out and they collect on your bills. So this company also then helps us with private pay. So you'll be getting phone calls from this company in Spokane. If you call in, you'll call a 773 number. It looks like you're dialing right to the hospital. It forwards to this company. They have all the access to your company as though they were employed in-house to be able to help you. And the whole idea was so that it's seamless for the patient, that it shouldn't be any different experience for you if you're calling Brenda, who's housed right here at the hospital, which we call it 711, which is the old clinic, or whether you're getting the person in Spokane. The other data we took a big look at too, and as Brenda was mentioning, we added this new RCM process, which is revenue cycle management process, to make sure that these claims, hospital billing is incredibly difficult and complicated, and one of the changes that we've gone through between 2009 and 2019 is ICD-9 to ICD-10 coding. So I don't know if anyone's familiar with that, but we went from coding 13,000 codes to 68,000 codes. And so that makes a big difference when you're going on your bills, trying to take a look at them and make sure that they're as accurate as can be before they go out. And so those are some other changes that we've gone through and education of staff to make sure that they're just as accurate as can be before those claims are getting out. And so we do recognize that there's a few breakdowns in the system, and we're working very hard at correcting those processes, because we don't want you to come and have a great experience with your mammogram or whatever it is that you came for, but then get frustrated because your bill wasn't right the first time. So in Barb's case, I would ask that you give us a chance, and if you're having those issues, please know that Brenda or I are always available for phone calls. If we're out on vacation or off, our voicemail will tell you that, so then you can expect that you won't get that phone call in 24 hours, dependent on what our voicemail might tell you, but we are always available. Yes, ma'am.
This is almost October. When would you expect people to have different experiences with you?
I say right now. If you're not having a different experience right now with your billing or your responses, I say you get a hold of Brenda or myself.
For services right now. Since April is when we started this process with the new system. So any dates of service since April this year to current, if it's not happening fast and we're not getting a statement to you, or we're getting you a statement, you shouldn't have one because you've got a secondary insurance that should have picked up the balance. Those are the things we need to know about.
When do the statements go out?
The statements do not, okay. Until your insurance is paid, we don't send statements. We're kind of having a conversation about maybe changing that process, but we haven't gotten very far with that conversation yet, because the statements are an issue these days. So, but as far as, I'm so sorry, I just lost my train of thought. They go out once a month now with the guarantor statement, where you're getting one statement that has the multiple accounts that you have on it. It goes out once every 28 days. So actually, Wednesday last week, we checked the statements that were going out, and they physically went out on Thursday. Okay, so every 28 days is when you should receive a statement. Now, that's the guarantor statement process with our current system. Okay.
And as she mentioned, you shouldn't receive that statement until you have the patient balance is due, not until your insurance is paid. So I don't want to take up the whole time, but I wanted to make one other note of information that we took a look at. So also, when we took a look at the percentage of denials from 2009 to 2019, in 2009 the percentage was 3.66% of denied claims, which means the claim was denied and then resubmitted. As of August of 2019, we're at 0.55%. Our goal is less than 2%. So we are really exceeding that goal. However, we wish we never had any denials, and we wish that we never had any complaints in the business office. But we are making some progress.
So I'm watching the time, and I know we have about 25 minutes left. Is it okay? Are people okay if we switch off and allow others to ask?
Oh, no, I'm great.
Thank you. You've been very patient. Thank you.
No problem. So I also voted no, and a couple of things.
And again, thank you for being here.
Absolutely. And I didn't vote no because I don't want the hospital to succeed. I would like to have local health care accessible and good. So one of the fundamental truths of customer service is that one bad experience will wipe out 5 wonderful experiences. And when people were talking about their problems with billing or their problems with competent health care, the general global response seemed to be, it doesn't matter. That was then, and this is how we're going to go forward, and here's all the wonderful things we're going to do. But nobody addressed these real issues on a global basis so that everybody got that information that says, yes, we're going to make improvements in billing. Yes, we know there's a problem. Yes, we know there's a problem in recruiting and retaining competent staff. All of this information here tonight is great, but had it gotten out in a more global, and people thought you cared about their complaints, I think things would have changed. In terms of financials, your annual fiscal audit for 2015, 2016, and 2017 all show net operating losses. So that concerns me in giving you $19 million if the last 3 years and 18's information I couldn't find. So, I mean, just as a trend, I consider that a problem. And the other reason I voted no, and this is not an entirely KVH issue, this is a community issue. I work for the county, and the county is facing the same issue. PUD, in situ, all of the big employers are having issues with community development. So you build this great big facility and you get these high income earners who, you know, are pleased with this facility. Where are they gonna live? Where are their spouses gonna work? Who's gonna watch their kids? I mean, there are big community issues that are so much bigger than just KVH. And I think that KVH, the county PUD, all of those people need to work on focusing some energy into that issue so that the community can succeed and then KVH can succeed.
You're talking about, I would call that infrastructure.
Yeah,
Daycare.
I mean, I know, like,
yeah.
Public Health offered a position to a clinical nurse division manager who accepted the position and then went looking for housing. She called back and said, nope, never mind, not taking it. I mean, it's not just KVH, but higher income earners don't want to live in the homes that are available here.
King Barbara's. I'm running Barbara's house.
Thank you.
I've been a pretty strong advocate that I'm not going to vote no. And the reason I voted no is some of those issues that really are outside of KVH's control. The building is messed up, they're getting it cleaned up. I've met with this lady, it's clear that they have gotten some issues, and I've had colossal nightmares with billing, 18 months later, but, getting bills. But there are some systemic problems with the communities. We have an aging population. We've got young people going away. So we do need to face the fact that guys like me are, going to be a drain on the system. But MCMC's here tonight, right?
Yeah.
Okay. I went to MCMC for a dermatologist. They haven't been able to replace it. And that's the Dalles. Okay, how are we going to get people here when the best thing we've got going for ourselves is a 1974 double wide? I mean, those are really systemic problems that you face in trying to attract people to come here. We have to get in front of that issue. Republic's got those problems at a management level. The larger employers certainly do. The county faces it. But here's some of the apathy that comes in. We belong to Grace Brethren Church. They decided they're going to try to move towards a daycare. So they started an after-school program. Everybody, we need an after-school program. This will be great. How many people signed up? 2. One family, 2 kids. And so all this, pardon my French, but bitching and moaning, and there's a facility, and it's cheap. It's not being utilized. So I don't know what that means, but when you're trying to attract higher income earners, they may have different expectations than this community can deliver. And I think some of that needs to happen with
Partnerships.
KVH getting together with Republic Services, getting together with the county. I mean, those are going to be a problem.
So can we address, Heather, your concern about a net operating loss? It is a valid concern. However, we are 75% Medicare and Medicaid, our revenue comes from. And it's on a cost-based basis, and they don't cover all your costs. So I'm sure the state, Washington.
60% of all rural public hospital districts.
What was it?
60% of
60.
all rural public hospital districts in our state don't break even from operations.
So I've been here 10.5 years. We've never, during that time, I don't think, except for with grant, we've had some different grant funds that have helped us overcome that. So we make up the difference with our maintenance and operation levy and with grant funds. We look for alternative ways to generate that revenue and make us whole. So it's just as a critical access hospital in a cost-based environment, the math doesn't work.
Here's the concern, is if you take this 20 million and you expand the size of the business, is what you're talking about doing, if that loss is the same percentage, instead of $1.7 million, it's gonna be 2.4 million.
So
how do you accommodate?
Yeah, that's a great question. So we had a feasibility study done with an accounting firm that also does cost reporting. So it's kind of a good thing to have the tax dollars support the bond, because in a cost-based environment, you do this big, $20 million project, you have the interest expense and you have the depreciation, which is cost-based reimbursed. So you get made whole because you're cost-based reimbursed for the building expenses that are depreciated and then interest, and you get the tax, the bond levy proceeds to actually service the debt as far as cash flow. So it does work. It does work because of that. Now, if the reimbursement methodology changes, then you have to play a new game. And the critical access hospital reimbursement came out in the early 2000s, and so adjustments were made then, and it's a game that we play.
So one of the real problems, Jonathan, you can testify to this about how much per square foot. I mean, if you think building a house
cost, yes.
is expensive, try building the new OR rooms.
Yeah, it gets pretty.
So
It's in the $700 a square foot.
Yeah, and I voted against it, and we pay a lot of taxes. And I will tell you that that was one of the first bonds I have ever voted against. And the reason I felt so strongly about it is I thought you were asked, if you'd come to us with what I would term a realistic look at what type of facility you need, instead of going out and asking people what they want, that's gets open and question. Well, yeah, I'd like this and I'd like this. We've got your track record when you expand into other areas, like the living area that we had. That, runs 2 years and goes belly up, and you take it over and do something else. And the dental thing, those statistics might be valid for the general part of the state. We have 2 dentists in this town, and this is, and this,
They don't take Medicare.
They don't take Medicaid.
Who does? What dentist does?
Yeah, what dentist does, and why do, so I assume it's a loss leader. It's gonna
Because
have to be a
they're
loss
using the
leader.
emergency room, and it's costing thousands of dollars for that person to come to the emergency room.
But
the other thing, I would love to, well, I will say, we went through the check-in process this week, and it's the first time in 2 months, it didn't take 10 minutes for a returning deal. It was a very pleasant experience. You can look at this facility and see the IT needs work, and there's a lot of stuff that needs to be fixed, but we don't need to compete, I don't think, with Mid-Columbia Medical Center. I don't think we need to compete with what I consider some of the solid businesses of this town, including the pharmacy. I think that was an extremely underhanded way to come in and erode those contracts. And the purpose of the hospital district, which has public funds, and it has substantial public funds, is not to come out and be in competition with local businesses. It's to serve the community in a better manner, or to help serve the community. And all of us, my daughter was born in this hospital. We value this hospital. But I just really have a problem looking at the cost and the types of stuff you're talking about here. we're not gonna have a long-term care facility here. There's just too much risk and they're over 40 miles away, you know, either way. And you know, it would be nice, I would have said it would be nice, but it's not realistic. We have schools that with that new law, our tax dollars are going to be really demanded. And if you know, I think the way that's going, and if you come out to us with something that is an operational, you know, we've looked at this, we need to do this, and we need to improve here, that type of thing, but not, you know, extra operating theaters and all of, I thought it was way, it was a pie in the sky is what I thought when I looked at it.
I do appreciate you sharing your comments.
I just,
Can I go back here first, or is that?
She's been waiting.
Okay, if you've been waiting.
this is gonna be quick, I think.
Okay.
I just need to have something clarified. If our population is gonna be more 65 and older, that means more Medicare claims, which means less out-of-pocket money, correct? Am I seeing that properly? Which means, I mean, what is going to offset that higher deficit when you have a higher aging population in the next, 11 years? I mean, am I seeing that properly, or?
Medicare is cost-based. It pays better than Medicaid, so if some of those folks are moving from one to the other, that would be helpful.
Let's do one at a, I'm just gonna ask one at a time, okay?
I just don't understand how we're gonna make up a bigger difference. If we have, I'm not really seeing that.
So if I can just, if you'll notice, and if I did not do a good job explaining how we estimated space needs, that's on me. But it really is not pie in the sky. We didn't assume any increasing market share. We didn't assume taking volumes from any other place. We said, what's happening today, and how is the population growing and aging, and what do we need? And there's all kinds of algorithms that tell us it converts into space. So it really wasn't pie in the sky. And I apologize.
And the new cafeteria and all these things. I mean, there was a lot in that.
I apologize if that wasn't clear. If we don't have enough services here, what happens is people come into the emergency room. They wait because they can't get in. They come into the emergency room. Maybe they're sicker than they would have been if they'd come in 4 days earlier, and they end up in the hospital. And those costs are the costs of the federal government is saying we're not going to pay anymore. Figure out how to keep people healthier. And so the real focus here on all of the outpatient services is how do we prevent people from becoming so debilitated that they're using all of the high cost, high focus areas of the hospital. And so by having these outpatient spaces, what we're going to see is the better ability to manage people at a lower cost.
So is there going to be, like, the time a doctor spends with somebody and they're going to be actually helping them learn how to better manage their own health? Is that part of it?
It might not be the doctor, but we do have care coordinators,
some prevention
and
services,
diabetes educators, and we are trying to get those resources because the physician is a very limited resource, and you're trying to maximize them at the top of their license, the top of their scope. So by bringing in other services that can help support their practice by doing just that, the education piece. We have a diabetes education program. We have, Dr. Botham has COPD day, diabetes day. We're looking at other days that you have the all-in-one day, and you have the support, respiratory therapist there to do the training that's needed in that visit.
You two have been waiting very patiently.
You showed on your screen earlier that 70% of the primary care physicians are used in this area, and you indicated that 85% of those people use KVH as a source of their services.
So I hope what I said is that 70% of the people that responded to the survey told us that their primary care doctor was here at KVH.
Well, the question I would have in regard to that is the primary care physicians, where do you find them in this area? I only know of one or two that's been here an extended period of time, they move on with a very short, usually less than 6 months.
So the national average is just under 3 years that a physician will stay in the spot. We have beat that average, so it's good. We do recruit. We have Dr. Armerding here now. He grew up in Hood River, and he did part of his residency rotation and then came to work for us. So we work hard at recruiting. I'm sure MCMC is faced with the same thing. We try to offer, something different here than someone would get in the city, and sometimes providers are looking for rural locations that they don't necessarily want to work in the city.